Hi, everyone. Thanks for taking a few minutes as we talk amongst colleagues really about our experiences of interprofessional practice, good and bad, our thoughts about interprofessional practice, where we're at, where we have been, and where we may go into the future, and just sort of the world around us as we're living it. So I'm Sue Coffey. So nice to have a moment to talk to you a little bit more informally. My practice, as many of you know, is in the emergency department. And it is a passion that I can never let go of, although in my heart, I'm coming to realize that the practice I know is almost, it feels like it's from a different era as things around us are changing so quickly. But it is, high acuity nursing is what I think a dream of mine that I never realized until I was there. And so when I speak of my own practice, I think I'm so colored by that, by living through those decades working in a variety of emergency departments. Why don't you introduce yourself?
Me? Oh, hi, everyone. I'm Leslie Graham, and I'm the RPN to BSN coordinator at Ontario Tech Durham College. And my background is in intensive care, so the open heart unit at CVICU. And as I moved into an educator role, I was educator for CCUs, cardiac cath labs, CVICU, and inpatient, where I really believe that it is around the education and the support of nurses that we really develop those interprofessional skills. I am also very passionate about critical care nursing. That's where we have to use our expert skills, especially communication, role clarification, to promote patient safety. So it's really in critical care that I really find my passion. And I'm so glad to be here to be part of this interprofessional conversation, because I think that a lot of times we can do a lot of practice or in simulation. So we have also developed some interprofessional simulations.
Hey, Selena, how about you? Would you like to say hello and tell us a bit about yourself?
Yes, thank you. I'm so happy to be here today. And I'm an assistant professor at York University. My background is in pediatric cardiology at the Hospital for Sick Children. And I worked in the medical surgical unit, rotated through the cardiac ICU and cardiac cath lab, as well as the inpatient clinic. My experiences with interprofessional practice really stem from a biopsychosocial model whereby everyone includes each other in team discussions regarding group processes. So it's not really that each discipline is focused on their own domain and care for that patient, specific patient, but it really is the blending of the professional skills and planning for quality and safe patient care. So I'm very happy to be part of this discussion, and thank you for inviting me, Sue.
Thank you so much, Selena. And Charles, my partner in crime and co-author, co-editor of our textbook.
My name is Charles Enyedem, and I am a professor at Nipissing University, and I primarily teach in our online RPN to BSCN program and have been doing so for quite some time, teaching that cohort in different universities. My background practice-wise is mental health nursing, and that is one of the areas where interprofessional practice is probably, I would say, most visible in a tangible way, because almost all everyday interactions really do hinge on this a team model whereby you have to be in that constant connection and communication with each other to plan care, because care is so much about the psychosocial and what is happening, not just in the patient physiologically, but in their world and in their environment. And so, and because of some of the issues related to mental health, it's so helpful that we're all on the same page. So siloed or even multi professional models don't really work in the psych environment if you want to be therapeutic, because we have to share roles. We have to continuously be negotiating with each other around the care of patients. So I'm really pleased to be here today to have a conversation with you about obviously something that's fairly passionate for me, given that we actually wrote this book. So again, thank you, Sue, for inviting me.
And Hildy, my current co-conspirator, as we both are teaching IPP.
Absolutely. So I'm Hilary Zitzelsberger, and I'm teaching a section of the IPP course with Sue Coffey. My background is community health, primarily women's health, violence, working with people with disabilities, and community health, very much like Charles just said. Community health is all about partnerships across numerous sectors. But it only functions when we're working in partnership with one another. So interprofessional practice is really important to me. And I'm really happy that we're talking here today.
Thanks, Hildy. And over to you, Arleen.
Okay, thanks so much for having me here today. I teach with Sue and Hildy and Leslie in our collaborative nursing program at Ontario Tech. I'm the second year coordinator, but I mostly teach in year 4 of the nursing program. And I must say that sometimes when I get in groups like this, I think I'm so blessed to have such a great group of people that I can count on all the time. It's not just, you know, occasionally that I can turn to you and say, I need help with something, but I think our interprofessional group as instructors, professors, is simply amazing and so supportive. And along with my team, I also have Selena and Charles and a few other wonderful professors in other programs that I can lean on for support and help. My background is in pediatric intensive care, and I think that is a passion that I will always have, knowing that you're not just caring for the patient, but you're caring for the parents and the families that support these poor children who are going through a lot of difficulties. And I think this is where we rely upon one another as well as interprofessional teams to support one another, because caring for patients, pediatric patients, can be very trying, very upsetting, very passionate in what we feel. So I think we've all come to really appreciate how important it is to have people that we can rely on in our workplaces. So once again, I'm really happy to be here with you today, and I'm really not on the beach, so don't report me.
Thank you all. And this is Kate, my daughter in my arms, who is at the moment falling asleep. So she'll take part in the conversation in her slumber. You know what I wanted to just say, our students will have had an opportunity to look at that organizing framework. And I'm just going to let you all, I'll share with all of you. I know some of you, we've talked about it before. Hildy talks about it herself in her section of the course. And there's a national interprofessional competency framework. But for Charles and I, we really developed a framework that we thought was very much driven by our own experiences, the experiences of nurses and other health professionals, and really the focus of what practice is really like. And so within our framework, there are 3 dimensions that we talk about. There's the task at hand. So in any situation, in any interaction, what is the task? Is this a task focused interaction? There's the relationship dimension. So is this all about, is this gathering, is what we're focusing on, is our priority about relationship? Is this process oriented? And I'm going to bring an observation in just a second based on even our introduction. So is this a process oriented focus? And also within any situation, there's the context. So what is that context that we are all experiencing? And even before we hit record, we were all talking about COVID. So I know that's going to come back into the conversation here. But one of the things I wanted to point out, so and in many situations, we've got the task, we've got relationship element dimension, we've got process dimension, and we've got context. All of those things play out in a situation. And sometimes it's much more focused on one thing or another thing. One of the things that I thought was interesting, as we looked at our introductions, as I was listening to our introductions, was thinking about process, and in particular how the team gets together, how we work together, how we focus on the day ahead, or how we stay connected within an interprofessional framework. And Charles and Hildy, both from your community background, really focus on that getting together, having that very formal opportunity to begin the day, to focus on who are the patients, how is the team working, what is the plan, where are we going from here, sort of that somewhat more formalized process. Charles, when you worked inpatient, that would actually happen physically there. Hildy, when you work community, it would have been different, because community often for you might have been an individual practice within the context of liaising, right? So not always within the team physically present, but sometimes through that liaison.
Often acted in a liaison role, absolutely.
Right, and so understanding one size doesn't fit all. But then when we heard from Selena, what I heard about you is that this was the way we always oriented ourselves. It was the culture of working within the context of a team, that there was no one health profession, that it wasn't a hierarchy of health professions. Each member of the team didn't look at the patient just from their own perspective, but it was a shared vision of what is the care for that patient, how are we focusing on that? And that was within a pediatric context, a high acuity pediatric context. And from Arleen, I heard the same thing, that idea of working in high acuity. You worked in pediatric ICU, and that focus, that collaborative focus that was so embedded in it. Now, I'm just going to say, and I'll probably be the outlier, and maybe in retrospect, I'm just not good at interprofessional practice, because when Charles would tell me it's so important to begin to have this, in the morning, that we would have at the beginning of the shift, you would have that sort of time to discuss, or a time in the shift to pull the team together and to discuss what's going on in the emergency department. Now, and I don't want to be negative, but honestly, in the emergency department, in the midst of a whole lot of things, if someone said, let's just pull the team together, let's have a team conversation about how we're doing and how the team is functioning together and what's our goal for today, I'd be thinking, oh my gosh, I have to start CPR in a minute, so I don't have any time for this. That's not an excuse, and that's not a good interpretation of how interprofessional practice works in the ER, because it actually works beautifully in the ER, because we are so dependent on each other to have a vision that we bring of our own. So rather than saying, as Selena says, none of us looked from our own perspective, rather we had a shared perspective of putting the patient first. My experience in the ER was that each of us did have our own perspective, but our own perspectives were complementary, and that we worked in a complementary way, right? So I would for sure be bringing that nursing perspective very far forward. A social worker might be bringing their social work perspective very far forward, but it was very complementary. There was no hierarchy to it at all. It was very complementary in that sense. But the way we did that interprofessional practice was much less formal and much more embedded in the moment to moment to moment activities that happened over the course of the shift. And now for Leslie, for you worked in, again, a more formalized environment in the ICU and adult ICUs, as opposed to pediatrics where it's much more family care. I will just say, and you can tell me if I'm wrong, adult ICUs do have a little bit of a reputation sometimes as being somewhat hierarchical, or they can be somewhat hierarchical in terms of who is the boss, who writes the orders and other things. And did you experience that?
Yes, very much so. And not only just with medicine, but with nursing as well. So, and I can give an example of when a very well-recognized nurse made a near fatal medication error, and the whole team flocked around her to support her, because by that point she's nauseated and trying to vomit and weak-kneed, and everybody's there to support this very experienced nurse. And said, don't worry, we're going to take care of the patient. All the night staff stayed so that they could be present for the day, so they could make sure this patient was stable. The doctor said, don't worry, we'll keep the patient in the ICU another day. Don't you worry about it. And while some of the staff were nursing her and some of the staff were helping with the patient, that would never happen with a new grad. They would be held out to dry. And so that is the hierarchy, that nurses that are very experienced and well-regarded have those sort of perks. But I was really intrigued when you said about that culture. And I think it is the culture of the unit that really supports that interprofessional practice. And I see that shift now, and many of the ICUs I worked in have been older units, and there was especially a hierarchical model where, and don't forget, I graduated in the day when we actually gave our chair to the doctor when they came in, and they're the chart. So you want my chart, I'm charting, go right ahead. Here's my chair. And so things are now changing, which is so important, because we need to, for patient safety, we need to remove that power differential because it impacts patient safety. I can recall that there was times when we had a doctor that was very harsh with nurses, spoke very harshly, and you were, okay, I'll say afraid to call. You knew you were going to get your head bit off, so you did not call. And so you would wait till 5 o'clock. You were waiting till 5 o'clock to call the doctor on call to get the orders you required. That wasn't helping the patient. And so I'm so glad to see that pendulum swinging, that we are removing that hierarchy. I won't say it's completely resolved or dissolved, but definitely there is that hierarchy. And I think that is so important going forward. And I think of all the team members, an example, before I hand the mic over here, just that when we had a very messy cardiac arrest, it was an open chest, so blood and parts and pieces everywhere. It was really upsetting to the nurses. So as an educator, I thought, let's do a debriefing, a formal debriefing, and ask the social work to facilitate. And I invited everyone. I even got the surgeon, which is very unheard of in those days. I had everyone there, and I forgot one person, the ward clerk. I forgot the ward clerk. And they were equally as traumatized by this messy arrest. People were dropping blood on their desk, they were told to call a code. They didn't know what kind of code, and they were very traumatized. And I should always invite the entire team.
Yeah. Such a valuable point. And I'm going to hand over to you. I just want to say, you know who we often forget, and Hildy has reminded me of this. One of the most integral people on the team in a hospital, the volunteer. Right? Because it's not always about whether they're serving me or not, but are they serving the patient, right? And are they part of it? And they feel very much part of that team, but are often forgotten. That idea that we, with interprofessional practice, that we don't just stick with the identified regulated professionals, but we consider all the members of the team within any given situation. And sorry to interrupt, Charles.
No, I was going to comment on what Leslie said, and I think it really speaks to, going back to the framework, the contextual things that surround the interdisciplinary team. And I think that that's the reality of practice, is that the context often will shift and try to form the team. And so when you think about traditional structures that exist in hospitals, and let's face it, I don't think while we invested millions of dollars into IPP that we necessarily made the full shift in terms of our structures and systems to really then support it. So some of you may work as an OT, a unregulated healthcare practitioner, even a lab technician in an institution that values hierarchies or hasn't done enough to remove hierarchies. So in that context, when building relationship, it becomes very important to have that recognition. And I think that's why we built this model. Is the intent is to always have in the back of your mind, what are the factors impinging upon this conversation we're having in our team? Why did this go wrong? Beyond looking at the team, are there infrastructural things that made this a little bit harder for us to do? And I'll give you a perfect example. When I worked in inpatient psychiatry, while we talked a lot about IPP and we worked very hard at it, often we fell back into old habits. And so, as a new nurse coming onto the floor, I worked with nurses who were, as Leslie suggested, used to handing over the chart to the physician when they walked on the unit. And so we had to actually fight our own instincts and our own bad habits around this hierarchy to be able to make that team stuff work. We had to start to think about, we're not equal because the system doesn't treat us equally, but in our group, our opinions are of the same importance. And what we're going to do is honor each other's specialties and not negate one person's voice over the other because their credentials are held to higher esteem. But that takes a lot of work. And in the relationship domain, that takes a lot of self-reflection and getting to know yourself as an individual, how you respond to power, how you build relationships, and really making sure that when you bring yourself to the team, you've got that stuff worked out. Because if you don't, you can label your group as an interprofessional team, but you're not practicing it because you don't have your eyes and your ears and your senses focused on not just on those 3 domains, but the context that's shaping your relationships with each other.
I couldn't agree more. And one of the things that I find, Charles, in practice, we've moved to this idea of a team huddle. They talk about that a lot of instant organizational, one of the organizational factors, the context is that there's a model of that team huddle, and there's effectiveness in sort of pulling all that team together in the beginning. But often the team huddle is really focusing on the task. So the team huddle is focusing on what's the job for today, what is the priority of care, where are we going? And it's not so much focused on all of those dimensions, some of which are not always as evident as others. We always know what we have to do. We have to get certain patients, up for physio, or we have to get patients bathed, or we have to give medications, or, the certain patients are improving or certain patients are deteriorating, or whatever is going on. We often are focusing on the task element. That sort of is the bully in healthcare versus looking at the process dimension, the relationship dimension. So in that team huddle, we're not then breaking it open and talking about the bigger things because we've all got the work to do. And so recognizing that interprofessional practice goes much deeper than just that sort of we all get report together, we've all heard about it together, but it really goes to that fundamental cultural aspect of practice in recognizing that every single person's contribution is equally valuable, but it doesn't always happen in the moment. Not everybody is contributing in the moment. And so I'll give you an example that I always think is classic, and Hildy's probably so tired of hearing me tell all these same stories, but my friend, such a dear friend, was the charge nurse in an area of and the emergency department. And one day a patient who had HIV had a seizure in the bathroom. Now there were 24 patients in this area and there were 2 bathrooms. And in those days, I don't know if it's still the case, and somebody correct me. In those days, if the patient had a seizure, he hit his head, he had been bleeding on the floor. They managed to take care of the patient, but housekeeping would not clean up the bathroom because there was body substance, right? There was blood on the floor, and the nurse had to clean up the bathroom, clean up the blood before housekeeping would clean up the blood in those days. And so the manager of the ER came in and said, well, you need to clean that up before housekeeping would clean that up. And my friend said, I am too busy. I am looking after, the entire area here and all of the patients and other things. And there was a little bit of a back and forth, not a disagreement, but a disagreement of ideas. And my friend took that 2-inch wide, I'm sure this is not the purpose, I'm not recommending you use it, but I do love the thought of that 2-inch wide tape. What's that pink tape? That beautiful pink tape, and put a big strip up one way, put a big strip up the other way, and just put a big paper that said out of order. Looked at the man, she did all this while the manager watched and said, I guess that's where we're at, and went back to looking after her patients. Now, the biggest problem in that moment was that the bathroom needed to be cleaned, right? The bathroom needed to be cleaned. And so that's the task, but underlying it are a lot of issues. There is the relationship issue, right? So being told what to do, how are people collaborating, how are people working together, and other kinds of things. The role issue, which is really important, right? What are your roles within the setting? And there's also process. So process underlies that idea of policies and how do we develop policies and other kinds of things. And in the moment is not the best time to sort that out, right? So in the moment where there are 24 people who need to use that one single bathroom is not the best time to sort this out because there's so many layers to all of that. And in the end, as you can all imagine, it was an imperfect solution. The nurse manager cleaned the bathroom, but not effective, not helpful. And there was no progression towards saying, how do we get around, how do we work within this challenge? I'm sure many of us experienced that challenge of that body substance and housekeeping not looking after, not wanting to be involved in cleaning up vomit or urine or stool or blood or other things. So it's that idea that people aren't more or less important. Nothing is above us or beneath us, but understanding our role within the moment, the task at hand, the relationships that are involved, and the processes that are involved. And it's the smallest thing. The most important thing that could happen in that ER in that moment was to get a bathroom cleaned. And so it really is recognizing that in healthcare institutions, it's not just about saving lives. Of course it is, and that's a priority. You're not going to clean the bathroom before you're doing CPR. But on the other hand, everything needs to function, right? Everything needs to function. And so it often is looking beneath the surface and recognizing if we let everything fester, if we don't do anything about the way things have always been done or the way they are, a crisis will emerge and we will be unprepared to deal with it.
I was just thinking as you were speaking, Sue, I was thinking, imagine if the manager had looked at this nurse and said, yes, you are busy. Let me take care of this. How that would have promoted the relationship, how that nurse would have felt regarded and recognized for how busy she was. And I'm thinking, or he was, and I'm thinking it would have just changed the tone of that whole situation.
And that's where we come into communication. But also I would take it another step further to say, yes, you are busy and this is clearly not working. Let me take care of this now because we're at a standstill in terms of roles and whose responsibility this is. And let's also bring this forward in the organization because this is not working, this demarcation where body fluids have to be cleaned up by one person and other things. So let me bring it forward, moving forward to the organization so we have a better process moving forward. And then I think you don't feel so stifled, so much like it's you against me, or we're struggling in the moment.
You know, Sue, I think what you're talking about highlights, and I believe it's on page 26, which is the problem identification and resolution process, because I think one of the things that I've been hearing everyone talk about, and I think again, in areas where practice moves a little bit differently, you have perhaps an opportunities to continuously do this part of processing, which is important for teams. If you know anything about team theory and the stages of team development, one of the key things is this constant reflective practice. Now, it is embedded in nursing that we do reflection. It's not in every other profession or every non-regulated profession or group. And so I think oftentimes nurses want to process a lot of things, but other professions, it's not part of their culture. So there is that cultural aspect of it. So what this whole idea of interprofessional practice is doing is, in many ways, trying to get everyone to speak the same language in terms of how things are done and how we relate to each other. And a big part of that is processing. So as you highlighted, there's a problem here. And we put a Band-Aid solution, whether it's the X across the door or the manager cleaning it up. But what's really going to make or break this relationship and determine whether we as a team can function is that level of processing, is that idea of going back and saying, okay, what was the problem here? And so when you look at that process model that we have in the textbook, it asks, where did the issue lie? Was this a contextual issue? Is this about a hospital policy? Is this about how we relate to each other? Do we just need to work on our communication with each other, you know? Because let's face it, we're all human beings and certain people we get along with more than others. And sometimes when you've got different professions working together, as much as we'd like them not to, there are still silos that exist. And so, you know, it's human. And this is why we talk about in the book, this idea of, you know, it's not rocket science what we're doing, interprofessional practice, but it takes an understanding of some very fundamental ideas. And one of them is psychology. So thinking about how, as people, when we are in situations where we feel attacked, defensive, stressed, we tend to turn into ourselves and we instinctively worry about us. And so when I hear that story of this battle, the nurse is saying, look, I've got all these things to do. Like, are you kidding me? You want me to clean the floor right now? And there might even be some feelings of subjugation, some feelings of, you know, hierarchy in that moment. And the manager is just saying, look, like, this is the policy, and I'm not really trying to tell you anything that you don't know, or I've got other things to do too. You don't know what my workload is. But the idea is that in these heated moments, we may not be able to separate ourselves and really look at things objectively. And to be able to move from this experience and grow, you need to get back to that processing. And so when the group sits around, or maybe it's just those two individuals having a talk and saying, you know what, there's some issues here. One, the hospital needs to look at this process. The context within which this is working is not the case. And maybe sometimes it comes down to we need more bathrooms. You know what I mean? It's totally not about the group. But when you look, if you're not examining it, you would never know that, yeah, there's some process, or there are some relational aspects here that we need to take care of. We don't communicate well. You know what I mean? We know these are not our patterns. And then brainstorming and going through that process. And I think that what's beautiful about the model that we've created in the book is that that process is probably a process that's familiar to everybody, a problem identification process. In nursing, we call that the nursing process. In other professions, you know, it is about, you know, problem solving, whatever way you want to label it, but it's a process we're all familiar with and we can engage in it. It's just that when we're talking about IPP, we're looking at very specific issues that are at play when we're talking about how we relate and work together for the betterment of patients. So I'm glad we're having this small little example, which probably may have taken like 5 minutes to play out, is a perfect example of how there's so many elements to this and how that incident can be used to actually build teams and make the team stronger.
I like how you said that, Charles. And one of the things that I think about is when we talk about interprofessional education, so IPE, we say it's about learning about each other and with each other. And sometimes that can be very, very formal processes. We're all in a room. It's been set up that we're learning in that particular way, but there's learning that happens on the fly through every situation a team is going through or groups of people are going through. And in learning about each other, we often talk about learning about the roles of other healthcare providers, learning about their scope of practice, things like that. But it's also learning about responding in the moment like that, how the team comes together and learns to process, developing a shared language or learning somebody else's language if we need to do that. And those things happen very deeply in practice. So I always think it's that willingness, the openness, the willingness, and the curiosity to go into relationships with other people. That way, within our professional lives, within a team of people that may be quite diverse to who we in fact are in all sorts of ways, right? So personally, professionally, many different ways, and the importance of that. And as you guys both say and have written in the book, that the relationship dimension is really important. And if that's not working, often other things can fall apart. If we can't talk, if we can't communicate, if we can't problem solve, if we can't process, then other things fall to the wayside and don't work.
And
I think that's
add to what
important. Whoops, sorry, I'm just going to jump in, Hildy. I think it's so important. And one of the things that strikes me, Hildy made a kind of an offhand comment the other day to our TA. So you said, Sue is fast and I am slow, and we meet up in the middle, not slow and getting something done, but how we process and where we get to it. And we both get to the same place, or we bring different perspectives and other things. But so it's not just recognizing that somebody may have a different cultural background or a different practice background or different thing, but it's that people, that the uniqueness of a person is not just their feelings or their experiences, it's also how they think and process and enact their role, and respecting that it doesn't look the same. So in practice, I could imagine, Hildy, in the midst of things, that there might be some tension between you and I think of an example and of course my dog is barking, but I think of an example of you saying that when you were doing, you were working with some forensics nursing and some sexual assault practice, and that you would be just trying to get some juice for your patients, and the staff would sometimes just block you. They don't have time. This isn't the juice for you. Somehow you don't belong here, or other things. it is that I don't have time for juice because I'm doing, again, I'm resuscitating somebody's life, and you're thinking, and I too am involved in critical care of a person, and my care requires comfort in the form of this apple juice, right? So it is recognizing that each of us possesses strengths, and if we were all the same, we would only get to one place, and that one place is going to be inadequate. It is going to be completely inadequate. And so we have to be open to seeing difference as strength, always seeing difference as strength. And I think as we get more stressed, that becomes hard. Don't you think? Just with me, as we become more stressed, there is less time. There is a pressure to do something. And if I have to communicate in a more comprehensive way because someone is interpreting things differently, or they're looking through a different lens, it feels more stressful. And yet, because we have different perspectives, inevitably we get to a better place, right? We open things up in a different way. And so recognizing that, I think that idea of difference as strength is really important. And I think even just how we cope. And I'm gonna take a foray to something we talked about again before we started recording. And I hope I don't put you on the spot, Selena. But I think it's your practice in pediatrics, which was exquisite practice, and your heart that is just the most open heart I know, right? Just the kindest and gentlest and most open heart. That would have been fostered, I think, by your practice, and you were drawn to that practice because of that and who you are. And yet, working in an area like mine in the emergency department, I think I'm very caring and very loved, but in a different way. And the space would not necessarily exist, or I would have to be able to see it. And so it's that idea of you and I express things in a different way, and yet both of our ways are so needed. And I'm going to take us on a little bit of a journey to say, and in this context, remember, we've got those three things. We've got task, we've got process, we've got relationship, but we've got context, those contextual factors. And we were talking about the situation now that we're experiencing in the face of COVID, where patients are not able to see any family, so they're behind closed doors, not able to see anyone. The nurses are working short, nurses are working exhausted. They're being assigned more patients that they can look at, and not only more patients, we have nurses. So for example, Selena and Arleen, you're both critical care pediatric nurses. To have a critical care pediatric nurse assigned to look after critical care adult patients means you are beyond what you would consider safe practice. And on the other hand, nurses are doing it because the alternative is the patient just dies, right? There is no one to care for that patient, and what can you do? So the trauma of that, and we had recently read a discussion about what's happening in the UK with that massive uptick in the numbers, and that ICU nurses in the UK are looking after at this point. I think I read in that up to 8 patients. There was up to 8 patients, which is just kind of unbelievable, right? When we come from a purist perspective, 1 or 2, right? 1 or 2, even in a team model, you might have a little, but 1 or 2, and now you're looking after 8. And I remember reading that part about that one nurse who struggled so much and realized after the fact that she was profoundly depressed. But in the moment, she did not even have time or a way to process how she was feeling, because all you're doing is going to work, trying to save lives, trying to get through the moment, just trying to get through moment by moment by moment, breath by breath. And then you're coming home. And she said, finally, it got to the point where she would come home and she would just be having dry heaves because she wouldn't eat anything for a 12-hour shift. She couldn't eat or drink anything. And she would end up like falling asleep on the bathroom floor every night. And her vomiting wasn't because she had an illness. It was her vomiting was because of what she had experienced, that the experience of the trauma of that shift for her. And so I think that context, now that's an extreme, but that context that we're living in right now for all of the members of the team is really impacting, I think, all of those elements. It's impacting the task. So what would have been the task a year ago in terms of patient care often is not the task now. Now the task is get them good enough to go home and we're sailing, open up a bed. The processes, I think, have fallen apart in lots of ways. And I think often what I think of in terms of process is around PPE and decisions that were made about that, and who was making the decision about what was safe, what wasn't safe, what can be reused, what can't be reused, who gets PPE, of certain qualities, all of that. That the process was just like decisions were being made on the fly practically. with evidence that was not being communicated well and potentially not solid evidence sometimes, and relationships that just fractured because nurses in the midst of other people were feeling so profoundly shut down and isolated, right? So the context becomes the shadow that takes over everything within those other dimensions. And I think for all of us, when we look at how all of us work and how differently we experience things, how do you use a framework like this to help you in the midst of situations that feel not just daunting, but kind of overwhelming? There's no simple answers, right? There's no simple answers for this. So how do you make that work?
I just wanted to add, so that's a very good point around the context that nurses are working at the moment. And the problematic really is all about the fact that, especially when you provide family-centered care at a pediatric unit like I was at Sick Kids, is that you've got to merge that interprofessional practice elements or skills and merge that with the family-centered way of caring for nurses, which can be a bit daunting for novice nurses at the best of times. And so, but really in the end, the patient, the family, because there is no age of consent in Ontario, but that family is really helping to make decisions, especially in the infancy and toddler stages regarding care. So, but ultimately I think myself reflecting back when I was a novice nurse, I really focused on the team, on the cardiology transplant fellow to make sure that we were working, with a vision that of course the family had agreed to, but not paying attention to little nuances. So an example is, I remember a doctor, well, I was actually a cardiology transplant fellow, who ordered a nasogastric tube for a 5-year-old who was awaiting a heart transplant. And the nurse gave me shift on the night report and said, oh yes, they've been trying. She's a very difficult mom. Her English isn't the best because she was actually an international. They were an international family. From actually, I won't say from where, but it was from, somewhere in the Middle Eastern. But anyhow, so basically, she was already labeled as a difficult mom. So when I went into the room and the doctor said, well, just make sure you get the NG tube in today into this child. He's failure to thrive and he's awaiting a transplant and this is not good. So I went into the room and the mother was I said, well, I brought the NG tube. And at the sight of the NG tube, she just started to cry. I was coming in to do my initial assessment, but brought the tube. I thought, well, it seems like they've all planned. I've got to get this tube in. So long story short, she was so visibly upset and her English wasn't the best. And I quite didn't understand what she was getting through. So whatever she had spoken to in the team previously really was not communicated. And it dawned on me, has no one called for an interpreter to really understand what this mother is going through? Maybe she's not difficult. So I did call the interpreter. They came and we put that on hold. And then we came to understand why she was really refusing to have an NG tube inserted, because she equated an NG tube insertion on her 5-year-old as, in terms of her spiritual beliefs, that this was the way he's palliative and he's going to die now. So it was just this moment that we all realized, and we called the chaplain's office as well. My gosh, people had forgotten. They were so busy, and this was around, it was around SARS time. And people were just so busy keeping up with everything. And I just thought, wow, we missed that small little piece, and people just labeled. And it wasn't until we had the interpreter. So in regards to your point, yes, I think it's very important that it's just not the regulated professions that are, it is part of the interprofessional practice, incorporates into the interprofessional practice model, but I think also the family really is the center of it all in a way, or if you're providing patient-centered care, right? So that's just my little story of how I realized that you really do need a team beyond regulated professions, that you need the interpreter, you need like someone was saying earlier, right? The housekeeping, the admin, as Leslie was saying. So that's just my point. It's a broad team. Mm-hmm.
So I wanted to share perhaps a different perspective during, what everyone's calling the COVID times. And I think there, in chaos, and I teach a lot in leadership about chaos theory and how, when you talk about transformation or transformational leadership, the idea really here is that in chaos, there is order. Ultimately, chaos is just unrecognizable order. But there's always opportunity in the most chaotic situations or even at the worst of times. And so, these are anecdotal images that I've seen on television, but what I'm also noticing during this time of COVID, that the shared experience and as horrendous as it is, the shared experience of such anguish and such devastation upon having to watch family after family or patient after patient pass away, where you as the nurse or the doctor or the respiratory therapist or whoever happens to be there providing care when the person is passing on, that shared trauma is also pulling teams tighter together, because there is this sense that together we are going to be much better. And of all the times in our system when everything else is failing, when the numbers are not there, our bed situation is terrible, at some point during this pandemic, there was not enough PPE. There is a lot of blame to go around everywhere. We're seeing that people are pulling together to support themselves and focusing on building their relationships. And I think it gets back to the framework, and I will say this always, that relationship is the foundation of human existence. And in healthcare, social care, it has to be the foundation before you can move forward. And I see that now that, more than ever, I'm seeing doctors and nurses and other professionals really seeing that we're all in this together. And when one of us is falling down because they can't hold it together any longer, the other has to be there to catch them. And I'm seeing a lot of that. And it's unfortunate that this tragic time in our history is the backdrop to that. But it also gives me a hope to see that we can come to each other's aid and support during that time. And I'm hoping that as we move, and honest to God, I do believe that's going to happen, as we move out of this time, some of the residual effects of that experience where we're supporting each other and much closer together continues to be the bedrock from which we continue to practice. Does that make sense? I think if we can hold it together at this point, we might emerge stronger in terms of our healthcare system, at least from the perspective of the professionals who are involved in providing care.
Charles, I think that's something really important that we reflect on. And as you were talking, I was just thinking yesterday I was picking up groceries for a neighbor. A year ago, I wouldn't have been doing that. I've sort of taken it for granted that I just do that. But a year ago, I wouldn't have known about the situation. I wouldn't have gone and done that or known to even offer it. And I think it's nothing. To me, it's like nothing. But when I think about the difference between now and a year ago, there is a difference. And I'll have a relationship for hopefully past all of this. And so I think that reflection on some of the positive changes that may have come about would be really important. So people, just like I did, the light bulb went off when you were talking. For me, that people do really recognize that there were positive changes in our relationships and care of one another. So that was lovely. That was a lovely thing to say.
And I just wanted to add a little bit to that, Hildy, too. I was thinking, I've heard a lot about people when they get to the end, or nurses when they get to the end of their shift and they're exhausted and tired, they will still stay on and make a phone call with their own cell phones to a family member and let that patient speak to their loved one, knowing that they can't come to the hospital. And I was thinking, I remember when our shifts would come to an end, we could hardly wait to just get me out of here. Like, I'm done 12 hours. Like, I have to go home. Now it's like, I can give another 30 minutes. It's not going to break me. And it's probably going to be the best thing that I could do that whole day.
Right. And interesting point. I'm just going to jump in here quickly, and then I'm going to hand over to you, Leslie. But I would think not only is it not going to break them, I think for many of us, it breaks us to not do those things, right? So to deny the things that we really want to do may break us. I also just want to take a quick second to focus on you, Arleen, and your focus, your beautiful focus on leadership, and how this also becomes opportunity when we look at that, again, that the task, the process, the relationship, how leadership, not just formal leadership, but informal leadership, leadership at the point of care, what we used to say, leadership at the bedside, is so important, whether it's COVID or not COVID, and developing yourself in your capacity for leadership. Oh, Leslie, over. I interrupted you, Leslie.
Oh, that's quite all right. That's a good point. Just building on what Charles was saying, I think that you're absolutely right, Charles, in sort of thinking about what has come about that's been positive as a result of COVID. And when we think about some of those teams that they're creating in the ICU, one RT, one RN, one float RN, one PSW, what's become apparent is their roles, what is their contribution to the healthcare system. And so I did not know that, for instance, an RT can administer blood products. So that really helps with that role clarification. And so I know that they've got that covered. So then that's part of their role. And so we can work collaboratively with the patient so that they can get the blood transfusion that requires. So I think it really has helped with role clarification of the different contributors to the team.
And so as we think of where we're finding ourselves right now in interprofessional practice, imagining our own careers, where we find ourselves now, as Arleen says, we continue to practice interprofessionally. We're having a conversation today with colleagues from across a variety of institutions, although we're all nurses, and I would say that often is the case, that there is intra-professional collaboration within nursing and the interprofessional collaboration that happens as well, and breakdowns in both of those. I'll for sure, I have worked many times where there are tensions between the RNs and the RPNs, or tensions between one shift line and the other shift line. The night shift didn't do what they were supposed to do. The day shift didn't get their patients bathed, things like that. So for sure, the intra-professional conflicts that can really impact all of those other dimensions, impact relationships, impact even tasks, getting things done, because you end up with bad feelings and you don't want to help. I'm not going to help the nurses on the next shift because they never do anything anyways, all that kind of breakdown that can happen. But beyond that, when we're looking at that interprofessional practice, whether it's in a hospital setting, in a community setting, as Hildy works, in an educational setting where we still work as nurses in our practice as nursing educators, where does this leave us? Where do we, as I think back on my practice, there's no question that the evolution of interprofessional practice is remarkable. So as with Leslie, I graduated at a time where nurses would stand often when the physician came into the nursing station, or make sure there was a place for the physician to sit down. You'd be nervous if the physician was going to ask you questions, because you would want them to not be stern with you. That has moved. We've moved a long way from that to be much more respectful and to work very hard at collaboration. But it still can break down. Any thoughts from anyone else?
Well, I don't know if you get to this chapter in your course, but at the end of the textbook, there's a chapter on intersectorial collaboration. And when we wrote the book, I think that our thinking was we're thinking big idea sectors, so big sectors, education versus healthcare and whatever. But I think you can bring it to a microcosm and understand that even within healthcare, there are a lot of different sectors at play if we think about a sector as a group. And so there are healthcare professionals, but then there's the administration of the hospital. There is the housekeeping staff. There's nutrition. And yes, nutrition, I guess you could also put that in, but there's librarians in the hospitals. There are researchers in the hospitals who are not attached to healthcare. And I think one of the things that I would like to see moving forward from this experience of COVID is to understand that the gains, despite all the tragedy, the gains that we're making, and this goes back to my other point, is because we're realizing that we have to work together. And that means sometimes putting our egos aside, putting a sense of importance aside, and understanding that, you know, the hospital administration isn't your enemy. They make policies and stuff that may not help you, or you perceive they don't help you, but even understanding, and I teach a course in research or not research, leadership. I do teach research as well, but in leadership course, we have an assignment where our nursing students who are RPN to BSCN have to interview a leader within their infrastructure or wherever they work. And typically they will interview a manager, and the manager may or may not be a nurse. And what is acutely interesting about the papers that students write is the aha moment when they realize that everything they believed about the manager went out the door, because they realize that the intricacies of being a manager in today's healthcare system is not black and white. And I think even as staff, we may sometimes look at the decisions and think about it as a black and white thing, but to even get a little insight into what is happening for that individual changes that person's entire orientation to the work that they do and the relationships that they have in that organization. And I'm really hoping that we begin to understand that if we are going to make an impact in the lives of people. So I'm not just thinking about healthcare, I'm thinking about health broadly defined as wellness, or our ability to thrive within our society, that we need to begin to bring those silos down and understand that, you know, we all need to try to get as close to being on the same page, because we're all working for the same thing. The administrator in the hospital is working for the benefit of your patient. You may not see that, but that's why they're there. Yes, we're all getting paid, but I could have been a lawyer, I could have been something else. I could have been a fashion designer. I chose to work in healthcare because I have a particular orientation to helping people in this particular way. And I think anyone who even dabbles in that realm has to have that, even if it's housekeeping. You know, there is that sense that there is an interest in helping people. And so I think if we start to build on common denominators, I do think this idea of an intersectorial approach to care is the next new wave. It's the next place that we need to move. We haven't perfected in interprofessional practice, but I think one doesn't require or negate the other. I think we can level up, as they say, and start to think about how best we can really create an integrated system of care.
Any other thoughts as we're getting to the end of our time? Such a fascinating conversation. I'm so grateful to have the opportunity to talk to you all. I could talk and talk all day, but any thoughts? Well, it looks like I think we're good for the moment, although I'll turn off the recording and we'll probably talk on and on again. But I really want to thank you all for coming and for sharing your own experiences, your own perspectives, for taking part in this kind of dialogue. It's so important that we have an opportunity to both model what we do, but also talk about the good and the bad of what we do, and our own beliefs, our own experiences. And to do that just sort of honestly and informally, and really have an opportunity for all of us to spend some time together in this time where we're all so separated and living in our own silos. So thank you for spending the last hour and a bit with me, and for taking part in this wonderful conversation.
Thanks so much, Sue.
It's been great.
And Charles and everybody, thank you.
Thank you.
This has been quite fascinating. Thank you so much.
Oh,
Thanks for having me.
Oh my gosh. And you know what? And honestly, Hildy and I will be calling upon you again, no doubt. But it has been.
Okay.
Thank you guys. All right.